An introduction to critical care, presented by me, your host, Pat Nelligan. In this tutorial, we're going to look at the patient who's in the ICU who's attached to a breathing machine, a mechanical ventilator, whether it's a non-invasive ventilator or a standard mechanical ventilator. Assessing the critically ill patient. Part 2, pulmonary. This part of pulmonary assessment looks at mechanical ventilation. In the previous tutorial, we looked at monitoring ventilation, and I discussed blood gas analysis and the relationship between pH, PaCO2 and bicarbonate and why it's so important in critical illness. I looked at underventilation versus overventilation, and then I discussed airway gas monitoring, and that's capnometry and capnography. In this tutorial, we're going to look at mechanical ventilation, and I'm going to focus on pressure limited modes of ventilation, particularly pressure support, volume control ventilation, and non-invasive ventilation. To understand mechanical ventilation, we need to build a breath. I believe to understand mechanical ventilation, you need to understand ventilator waveforms. This is a graphic of airway pressure and gas flow. On the bottom, we have airway pressure. This is usually abbreviated as PAW, pressure airway. I'm going to draw a line, and that is the baseline pressure. For you and me, right now, it's the prevailing atmospheric pressure. Above this line, the pressure is positive, and below this line, the pressure is negative. When you or I take a breath, our diaphragm descends, and negative pressure is generated in the airway due to pleural stretch, and gas enters the airway until pressures equalize. And then we expire, and due to the elastic recoil of expiration, the airway pressure goes slightly above atmospheric. So the airway pressure is negative in relation to atmospheric pressure on inspiration and positive on expiration. If you measure the airflow into the lungs in liters per minute, you will also have a 0 point of no flow. Above this, the flow is inwards, and below this, the flow is outwards. That means out of the lung. During inspiration, flow is positive, and during expiration, the flow is negative. The pressure and flow waveforms are sinusoidal during normal breathing. If you go to the operating room and see a patient who is breathing spontaneously under anesthesia, for example with a laryngeal mask airway, you will see exactly these waveforms. If there is a reduction in functional residual capacity, we can apply a face mask and increase the pressure at the start of the airway. This is known as continuous positive airway pressure, or CPAP. In this case, I'm going to draw a line at 5 centimeters of water, and that will be the CPAP level. When the patient takes a breath, the waveforms are identical to what we've seen before. The only difference is that the airway pressure is raised, and the airway pressure remains negative in relation to CPAP on inspiration and positive on expiration. On CPAP, flow is proportional to patient effort. That is the negative pressure ramp, and the tidal volume is variable based on the depth of inspiration. Positive pressure ventilation involves pressurizing the airway during inspiration. We usually build the breath from a foundation of CPAP, but in positive pressure ventilation, this is known as PEEP. The PEEP is needed to maintain functional residual capacity. If you don't use it, you tend to lose lung volume. Next, the machine needs to know when to give the patient a breath, and we use the term trigger to describe this. There are only 2 ways that this can occur. Either the ventilator is programmed to give a breath at a specific time interval, a mandatory breath, or the patient takes a breath themselves, triggering a breath from the machine. We are going to give this patient an assisted pressure limited breath, so we set the inspiratory pressure level above PEEP. The breath is delivered after triggering, and the gas flows into the lungs. The flow pattern here is triangular, reflecting a slowing down of flow rate as the pressure ramp between the patient's airway and the ventilator reduces. It's also known as a decelerating flow pattern. The airway pressure is held positive for the duration of the breath, after which the ventilator releases the gas, and gas flows out of the lungs, and airway pressure returns to the PEEP level. cycling to expiration may be timed or mapped onto the patient's effort. Exhalation is by elastic recoil and it's quite rapid, and then there is a gap between that and the next breath being delivered. Now that you understand the basics of positive pressure, it's time to look at our vent strategy. Remember, our patient is in respiratory failure. That means they can't inspire sufficiently to oxygenate or ventilate or protect the airway. And we need to have a good look at what's going on with the patient and how we can help them. And the first question that we ask is whether the patient is breathing spontaneously. If the patient is not breathing at all or is only taking intermittent breaths, then a controlled and assisted mode of ventilation is used. Those are volume control, pressure control, or volume guaranteed pressure control, and they may be assist control modes or SIMV modes. If the patient is breathing spontaneously and that is sufficient with support to generate adequate alveolar ventilation, the patient will receive pressure support ventilation or one of its analogues. I want to introduce you to a major rule of mechanical ventilation, and that is that tidal volume should not exceed more than 6 mL per kilo of ideal body weight. And this is pretty much universal for all patients. If you are delivering a specific tidal volume or inspiratory pressure and you're targeting a tidal volume, around 6 mL per kilo is the max. Of course, sometimes the patient will take a bigger tidal volume themselves, but you need to try and lock into this. Ideal body weight is based on height. The minimal tidal volume should be around 4 mL per kilo, maximum on controlled mechanical ventilation of 6 mL per kilo, and that translates into, for the average woman, about 350 mL, and for the average man, about 420 mL. So that's where I start. If the patients are particularly small or particularly tall, I'll stretch that out. The bottom line is very rarely do you ever give a tidal volume of more than 500 mL to any patient. Now let's look at the different modes of ventilation that we're likely to use, and I'm going to start with pressure-limited modes of ventilation. In pressure-limited modes of ventilation, you set an inspiratory pressure rather than a tidal volume, so you tell the ventilator to inflate the lungs up to a specific pressure, in this case 14 centimeters of water, and the lungs expand. Then, after a certain period of time, or else at a certain point where the flow slows down, the patient then cycles to exhalation and the gas leaves the lungs by elastic recoil and out into the atmosphere. At that point, the tidal volume is measured. It's always the expired tidal volume, and in this case the tidal volume is a pretty generous 450 mL. In pressure limited modes of ventilation, we set a specific driving pressure and the tidal volume is variable. That driving pressure is usually above PEEP or positive end expiratory pressure. So in this situation, we've started with a baseline airway pressure of 5. We've given 14 centimeters of water. So the plateau pressure that is expected, that's the pressure at alveolar level, is 19 centimeters of water. It may well be that you are looking for a lower tidal volume than this, in which case we would reduce the driving pressure, for example, down to 12 or 10 centimeters of water. And in general, these are the rules that I think you should follow if you're using pressure-limited modes of ventilation. The inspiratory pressure should not usually exceed 14 centimeters of water. Of course, sometimes it has to. The tidal volume should not exceed 6 mL per kilo of ideal body weight based on height, but sometimes the patient will drag out a tidal volume from the ventilator greater than that. And the airway pressure, which is the inspiratory pressure plus the PEEP, should not exceed 30 centimeters of water. Occasionally it has to because the patient is morbidly obese. But those are the rules that you will be expected to follow. Now let's start with pressure control ventilation. If you're going to use pressure limited modes of ventilation, you're going to find it a little bit confusing because there are so many different versions of pressure limited ventilation. If you're in the operating room and you see pressure control ventilation, most of the time that is pressure control with no assistance for the spontaneous breath. In the ICU, we don't do this. We use usually an assist control mode. There are two versions of this: pressure assist control and volume guaranteed pressure control. I'll talk about the latter in a couple of minutes. But pressure control in the ICU, when we say that, we mean pressure assist control. And what's important about that is that when the patient takes a breath themselves, the airway pressure is targeted at the limit that you have set, and the duration of the inspiratory time, which is a key component, is always the same. So every breath is essentially a facsimile of every other breath, but the tidal volume will vary from breath to breath because the patient augments the pressure ramp when they take a slight negative deflection on inspiration. There are a couple of intermittent mandatory ventilation modes that are used in pressure control. There is synchronized intermittent mandatory ventilation, pressure control, and bi-level. It's also known as bi-vent or bi-PAP sometimes, and this is a mode where you have a pressure control ventilation where the spontaneous breath is completely independent of the ventilator, and you can do all kinds of things with that. And finally, there are spontaneous modes, and the most commonly used one of these is pressure support ventilation, which I'll discuss in a minute. There's also a version known as volume guaranteed pressure support or volume support, and another one called proportional assist ventilation. From your perspective, working in the ICU, of the pressure modes, you need to know pressure control, volume guaranteed pressure control, and pressure support. So let's have a look at pressure control. And this is a very, very straightforward and simple mode of ventilation. And in this case, the ventilator intermittently gives a patient a breath that is targeted at a specific inspiratory pressure level, whether the patient takes a breath themselves or whether it's a mandatory breath. It's always the same airway pressure. The gas flow is always decelerating because the ramp is greatest at the beginning of the breath, and as the airway pressure climbs, the flow slows down. So this is what pressure control looks like. The key thing in pressure control is that the duration of the breath is determined by the inspiratory time that you dial up, and it's always the same. What inspiratory time should you dial up? In my view, you should start with a 1 second inspiratory time. Your normal inspiratory time is about half a second to 0.6 of a second. You need a slightly longer inspiratory time on a ventilator. 1 second is a good place to start. Sometimes you'll lengthen it, sometimes you'll shorten it. The major problem with pressure control ventilation is variability in tidal volume. While you may set an inspiratory pressure based on the tidal volume that is delivered by the first few breaths, you cannot be sure that the ventilator will continue to provide that volume. If the patient turns in the bed, moves their head, if the lungs stiffen up or loosen up due to a large diuresis, if there's a kink in the tube or an airway plug, the tidal volume may fall or rise dramatically. Now that's okay if the bedside practitioner, for example a nurse or respiratory therapist, is watching the volumes carefully. But when they are inexperienced or distracted, for example setting up lines or infusions or dialysis or helping with turns or proning, then there may be a problem. To resolve this issue, a mode known as volume guaranteed pressure control was developed. And this is an elegant solution. In volume guaranteed pressure control, the operator sets a desired tidal volume and a maximum airway pressure. That maximum pressure may be set at 35 centimeters of water, but the real max distending pressure is 30. There's always a difference between the two. Can be a bit confusing. The ventilator adjusts the driving pressure from breath to breath to achieve that tidal volume. So the airway pressure is variable, although this is rarely dramatic. Because of the variability from breath to breath, the tidal volumes will also vary a little bit and oscillate around that desired tidal volume range. This may not always be desirable. The operator sets the respiratory rate, the inspiratory time, because this is time cycled pressure control ventilation, the PEEP, and the inspired oxygen tension. The flow pattern is always decelerating, and the assisted breath is flow augmented, which means the higher the patient's inspiratory flow demand, the higher the flow generated by the ventilator. So the patient is really comfortable. There is no flow demand dysynchrony. It's a very comfortable mode. Volume guaranteed pressure control is often described as a dual control mode. The ventilator typically delivers a few breaths looking at airway pressure and resistance and compliance, and adjusts inspiratory flow and airway pressure to ensure that tidal volumes are achieved. But there is one thing you need to remember. tidal volumes are relatively guaranteed but not limited. Just because you dialed up 450 mils as your desired tidal volume does not mean that the patient will receive exactly that volume. Sometimes it will be 430 mils, sometimes it will be 470 mils. And importantly, if the lung compliance is very poor or you've set the maximum airway pressure low, then the breath will encounter the pressure limit and the tidal volume will fall. It is nonetheless an excellent mode of ventilation and very easy to get the hang of. On different ventilators, there are different names for this mode. It's known as volume assist control with autoflow on the Draeger. It's known as pressure regulated volume control PRVC on the McQuay servo ventilators. It's known as VC Plus on Puritan Bennett ventilators and APV CMV on Hamilton ventilators. There's also a version of this called volume support, which is volume guaranteed pressure support on a number of the different machines. This is what volume guaranteed pressure control looks like on the screen of a Puritan Bennett ICU ventilator. You can distinguish this from pressure control by two settings. The first is on the bottom left-hand corner where you can read AC Assist Control VC+. That's the mode on the Puritan Bennett. The second setting is the tidal volume. For pressure control, we would normally set an inspiratory pressure there. You can also see the inspiratory time. The arrow on the screen on the flow waveform shows you that the flow decelerates right down to the baseline. So this is time cycled mechanical ventilation. Now let's move on and talk about pressure support. Pressure support is the most widely used mode of ventilation in critical care and indeed on the wards in non-invasive ventilation. It's really a form of assisted spontaneous breathing. The patient initiates the breath, a flow of gas is delivered by the ventilator up to a pre-specified airway pressure, and the tidal volume is variable. The patient triggers the ventilator, and the patient actually cycles the ventilator to exhalation due to a process known as flow cycling. A key thing to understand about pressure support is that it is a spontaneous breathing mode. The patient has to be able to initiate the breath. If they cannot breathe to trigger the ventilator and maintain enough flow to ensure that they can oxygenate and ventilate, the patient cannot be on pressure support. Now let's take a look at a pressure supported breath. Nearly always when we are administering pressure support, we administer PEEP to prevent loss of lung volume. In this case, I'm going to set the PEEP at 5 centimeters of water. Next, we choose a starting pressure support inspiratory pressure level, or colloquially, the pressure support level. I am choosing 10 centimeters of water, so the end inspiratory airway pressure will be 15 centimeters of water. The ventilator waits for the patient to take a breath. That trigger may be a negative pressure trigger or a flow-by trigger, and when the breath starts, the gas flow is most rapid. The peak flow is determined by the pressure ramp. The patient's negative airway pressure plus the positive pressure. So if you're giving 10 centimeters of water and the patient generates -2, the pressure ramp is 12 centimeters of water. Regardless of how deeply the patient inspires, the end inspiratory pressure is always the same. The breath ends with a clip in the flow waveform demonstrated by the arrow here. And this is known as flow cycling, and that cycle time is determined by the peak flow. There is a setting on the ventilator that determines when flow cycling to exhalation occurs. And that's known as the expiratory sensitivity or the inspiratory flow cycle off percent. I obviously prefer the former. To understand how exhalation happens in pressure support, you must keep in mind two things. The first is that we don't like to hold our breath. As soon as we inspire, we almost immediately expire. The second is that large breaths are of shorter duration than small breaths, as the initial velocity of flow is higher. Now, this is applied in pressure support by using the expiratory sensitivity to cycle the ventilator to expiration at a specific percentage of peak inspiratory flow. In this example, I'm using 25%. The patient takes a breath and the peak flow is 60 liters. That means with the expiratory sensitivity of 25%, inspiration will stop when flow reaches 15 liters. The breath never reaches baseline, so you see this shaved off appearance on the flow waveform, and the breath immediately goes to exhalation. There is no inspiratory pause. This is what you see on the screen of a patient who's on pressure support ventilation. Again, on the bottom in the middle is the expiratory sensitivity, 25%. The patient is taking a breath and the peak flow is about 60 liters, and from this you know that that breath is going to cycle off at 25%, 15 liters. I want to introduce you to a concept that makes understanding pressure support ventilation very simple, and it's known as the spontaneous breathing index. Now, sometimes you'll hear about a shallow breathing index or a rapid shallow breathing index. They're all exactly the same, but the term I use is spontaneous breathing index, and it's very simple. It's the respiratory rate divided by the tidal volume in liters. That means that a 300 ml tidal volume is 0.3, so the respiratory rate is divided by 0.3. I'll give you an example of this. If the patient has a respiratory rate of 20 and a tidal volume of 400, the spontaneous breathing index is 20 divided by 0.4, and the result is 50. This is very good. The patient's taking generous tidal volumes with a relatively slow respiratory rate. Conversely, if the patient's rate is 30 and the tidal volume is 250, this is rapid shallow breathing. The spontaneous breathing index is 30 divided by 0.25, or 120. Let's look at the clinical pearl. The key number here is 100. If the spontaneous breathing index is less than 100, that is good. The lower that number, the better. A spontaneous breathing index of more than 100 is bad, as it represents rapid shallow breathing. The higher, the worse it is for the patient. And so we can use the spontaneous breathing index, the SBI, as a way of targeting the pressure support inspiratory pressure level. We'll start with an easy example. We have a patient who comes back from the operating room under anesthesia. They're put on a controlled mode of ventilation, and then over a couple of hours they begin to wake up and breathe up, and we want to change them to pressure support. Our goal here is a maximum tidal volume of 450 mils. So we start on pressure support of 12 centimeters of water, and the patient has 750 mils tidal volume, spontaneous breathing index of 20. Well, that's too much. We need to reduce the pressure support, so we go down to 10. Tidal volume, 650 mils, spontaneous breathing index 40. Let's keep going. Down to 7 centimeters of water, 550 mil tidal volume, spontaneous breathing index of 60. Let's drop the pressure support. Now we're down to 5. Tidal volume is that maximum goal, 450, shallow breathing index of 60. So this patient is now weaned on pressure support. When the patient is wide awake, obeying commands, sitting up in the bed, and able to cough and doesn't have a load of secretions, we will go ahead and extubate that patient. Very straightforward, but not commonly seen, unfortunately, in the ICU. And this is more like what we see. Patient starts to breathe up, so we put them on pressure support, and the pressure support is 12 centimeters of water with a tidal volume of 550, spontaneous breathing index of 60. So we'll drop the pressure support, and make sure you do this slowly, particularly in critically ill patients. That first patient, you could have probably dropped them straight down to 7, but in ICU, just be a little bit more cautious. So we go down to 10, and the tidal volume is 550, but that spontaneous breathing index is up to 80 now, so it's a little bit marginal. Tidal volume is still good and reassuring, so you should keep weaning that patient. We're going to reduce the pressure support to 7. It's apparent that the tidal volume has dropped quite a lot, down to 350 mils, so the lungs are significantly less compliant at this level of pressure support. The spontaneous breathing index is 90, and I would consider this quite marginal, and I wouldn't go any further. But if you did, what would you see? So in this situation, the pressure support was dropped to 5 centimeters of water. The tidal volume now drops to 250. This is very low, and the spontaneous breathing index is now in the red. It's 120. This is a failed liberation or failed weaning trial, and what we'll do now is we'll put the pressure support back up to 10 centimeters of water and wait and see how the patient does. Perhaps they need some diuresis, perhaps they just need a little bit more time. When weaning pressure support, you wean the pressure support level and I sometimes call it the pressure support inspiratory pressure level, but most people call it the pressure support level, against both the tidal volume and the spontaneous breathing index. If the index is greater than 100, consider the weaning trial to have failed. If the tidal volume falls below 4 mils per kilo of ideal body weight, be really cautious, irrespective of the spontaneous breathing index, because the respiratory rate may be constrained by opioids or other sedatives, and the patient may be failing, but not failing obviously. Now let's move on and briefly talk about volume control ventilation. Volume control ventilation is the most widely used mode in the operating room on patients who are paralyzed under anesthesia, and the ventilator circuit looks like this. I've drawn a bag-in-the-bottle ventilator. In the ICU, the ventilators don't have this. They don't have a bellows these days. The gas comes straight from the wall and it's sent straight into the patient. When you put a patient on volume control in the ICU, you dial up 3 things: the tidal volume, the respiratory rate, and the peak flow. The peak flow is the speed at which the gas goes into the patient. When the patient is paralyzed, it doesn't really matter what the peak flow is, but if the patient is breathing themselves, that flow rate needs to match the patient demand flow rate, or the patient will become desynchronous. You may or may not decide to set an inspiratory time for that patient. Normally, volume control is volume cycled. Once the gas goes in, it comes straight back out again. But usually these days, most doctors apply a slight inspiratory pause, so they time cycle the ventilator. If you work in the operating room, you will set an I/E ratio. By definition, you are time cycling the ventilator. In this situation, we want the patient to get a tidal volume of 450 mils, so gas is delivered through the system into the lungs expand, and we immediately get an airway pressure. Where is the tidal volume? We don't measure it right now. What we do is we let the gas come back out of the lungs by elastic recoil, and then we measure the tidal volume as before in exhalation. This exhaled tidal volume is so important in volume control ventilation because the tidal volume is fixed, and we want to be sure that the tidal volume that the patient is getting is the same as you dialed up. If it's not, there is a leak in the system. For example, the cuff may be down, the tube may be in the larynx, the catheter mount might be partially disconnected, there may be a problem with the end-tidal CO2 connection. There's a problem there, so you need to watch the exhaled tidal volume carefully. The key thing about pure volume control ventilation is that the airway pressure is always variable. Fortunately, there are far fewer volume control modes than pressure control modes. In the operating room, volume control is just that, a series of mandatory breaths delivered at time intervals. In ICUs, though, there are 2 different ways of giving volume control. One of them is volume assist control. That means that the patient receives a number of mandatory breaths per minute, and if the patient takes a breath themselves, that breath is a facsimile of the mandatory one. The tidal volume is fixed, as is the peak flow. Hence, there is a possibility that the patient might hyperventilate, but minute ventilation is guaranteed. Sometimes an alternative mode is used known as synchronized intermittent mandatory ventilation. When SIMV is used, it is usually used in the setting of volume control. And in this mode, there is a set number of mandatory breaths. And beyond that, if the patient takes a breath outside the mandatory breath window, that breath will either be unsupported or pressure supported. Let's go ahead and put a patient on volume control ventilation. The first task is to choose a tidal volume, and in this case I've chosen 450 mils. That is based on 6 mils per kilo of ideal body weight. The second task is to choose a peak inspiratory flow to set. In this case, we have decided on 40 litres per minute. Constant flow. The ventilator generates a constant flow of gas at that peak flow rate to the patient until the tidal volume has been delivered. Then, if you've set an inspiratory pause, the gas will be held in the lungs until that time has elapsed, and then the patient exhales. The pressure waveform looks like a shark's fin with a peak and a plateau pressure. In this situation, the peak pressure is 25 centimeters of water and the plateau pressure is 22. The peak pressure reflects the pressure within the major airways, and the plateau pressure, the pressure within the alveoli. The pressure we are interested in is the plateau pressure, and we don't want that to exceed 30 centimeters of water. When is volume control ventilation used? Some units use it all the time, either assist control or SIMV. It's used a lot of the time in the operating rooms in patients who have neuromuscular blockade, and indeed if patients receive neuromuscular blockade or are paralyzed, for example, from myasthenia gravis in the ICU, then we tend to use volume control ventilation. We also use it for tight control of the partial pressure of carbon dioxide in the blood, for example in brain injured patients or in neurosurgical ICU, and where we really want to control the tidal volumes of patients who are worried about ventilator induced lung injury, and that happens in patients with ARDS. Now that you understand the fundamentals of mechanical ventilation, you need to assess the patient's status on the ventilator. The most important thing is whether the patient, from a pulmonary perspective, is clinically stable. In other words, is the patient oxygenating and ventilating? If the patient is oxygenating and ventilating, is there any reason not to put the patient on a spontaneous breathing mode, such as pressure support? Sometimes you won't because there is hemodynamic instability or something else going on, or they're paralyzed. But if they're not, then you wean to pressure support, and then you wean the pressure support using the spontaneous breathing index. If the patient is not oxygenating and ventilating, what do you do? Well, let's look at ventilation first. Not ventilating means high partial pressure of carbon dioxide in the blood. How do you deal with this? You need to increase alveolar ventilation. And that is achieved by increasing the respiratory rate, increasing the tidal volume, or both. But sometimes you need to reduce the PEEP because lung units are overdistended. If the patient is not oxygenating, and we define lack of oxygenation, as you recall, by looking at the PaO2 FiO2 ratio, anything below 150 is not good, anything below 100 is severe hypoxemia. So what do you do if the PF ratio is low? Well, you can increase the FiO2 to stabilize the patient, increase the PEEP, or increase the inspiratory time. This increases mean airway pressure, keeps the lungs open longer, increases the surface area for gas exchange. But by far, the most important thing you need to consider is turning the patient prone. In my view, any patient with a PF ratio of lower than 100 should be turned prone unless there is a specific contraindication. Let's move on to non-invasive ventilation. Non-invasive respiratory support was one of the great innovations of the last 30 years. It can be delivered anywhere in the hospital, so the patient doesn't have to be in ICU, and particularly in healthcare systems where very few ICU beds are available, it allows doctors and nurses to care for patients who need respiratory assistance at remote locations. There is minimal training needed, the patients don't need to be sedated, and in the short term, you can use this while pathology reverses, and there is compelling evidence for the use of non-invasive ventilation in patients who have flares of COPD. Non-invasive ventilation can be delivered by purpose-built machines such as the one on the left, that's the Respironics or Philips Trilogy, or the one on the right, that's an ICU ventilator. All non-invasive ventilators can deliver CPAP, but not all ICU ventilators can do so. The Puritan Bennett 980 requires a mode that gives a little bit of pressure support. The term non-invasive ventilation is important to define. When you say NIV, there must be assistance on inspiration. The patients may or may not receive PEEP. Usually the support is pressure limited. That support may be time cycled, so it's pressure assist, or it's flow cycled. In that case, it's pressure support. Now, you're not going to use NIV for brain injured or unconscious patients with a GCS of lower than, for example, 8. Not in raised intracranial pressure, not in patients with undrained pneumothoraces or profound hypoxemia where you have a really low PF ratio, not in a patient with copious secretions, facial trauma or abnormalities or post-airway or head surgery, and certainly not in patients who are vomiting. And the one case where we kind of run into a bit of discourse about that is in patients who may or may not have a leak in their esophagus after esophagectomy. You can use a whole variety of different devices for non-invasive ventilation. Usually it's a facial mask that covers the nose and the mouth. It might cover the whole face, and sometimes it's a helmet. There is some differences in the terminology that's used to describe the mode of ventilation, and it's really important that you understand this. Sometimes you'll see the term BPAP. Now, the term BiPAP is a patented term for the Respironics ventilator, so a lot of the literature uses the term BPAP or bilevel and biphasic, but it is really analogous to pressure support, but it's delivered in a slightly different way in an ICU ventilator than on a non-invasive ventilator. So in the ICU, when we're giving pressure support, we give the patients a PEEP, and then the pressure support is built on top of PEEP. So for example, if we give the patient 5 of PEEP and 10 of pressure support, the plateau pressure should be 15 centimeters of water. In biphasic non-invasive ventilation on, for example, the Respironics machine, we set an EPAP and an IPAP. And in this situation, we've set an EPAP of 5 centimeters of water and an IPAP of 10 centimeters of water, and the plateau pressure is 10. So the EPAP is built into the IPAP. Using NIV in an ICU ventilator is relatively easy. Make sure, if it's available on your ventilator, to enable leak sink, which means that the ventilator will still pressurize the airway even if the face mask is partially off, generating a huge leak. The Trilogy ventilator has a whole series of different modes that can be used on it, and it can be quite confusing. But in general, you're going to pick one of two, either spontaneous or spontaneous timed. Spontaneous is usually used purely for CPAP, and that's fine. You just raise baseline airway pressure. If you're going to use non-invasive ventilation, I think you should use spontaneous timed, and that is essentially pressure support plus a backup rate. The patient triggers inspiration, the spontaneous breaths are supported, and the breath cuts off at a percentage of peak flow. It's just like pressure support ventilation. The value of using the timed portion of this is that if the patient goes apneic for any reason, for example, somebody gives them a bolus of morphine or else they just stop breathing, they will get a backup rate, and by the time the desaturation alarm goes off, the patient is now getting mandatory breaths. So I think it's a really useful way of safely, non-invasively ventilating patients, in particular in remote locations. So if you have a patient who is on non-invasive ventilation, this is the way you work the problem. Is the patient in respiratory distress? And if they're not, wean them to high flow. If they are in respiratory distress, whether it's rapid shallow breathing or just not ventilating, the thing to do is increase the pressure support or the IPAP level. You should go through tremendous effort to get a COPD patient who's presented with acute hypercarbia settled on this, because there are compelling evidence that patients with hypercarbia do really poorly if they're intubated. They do so much better on non-invasive ventilation. Now, if the patient is in respiratory distress and they're not oxygenating, absolutely you can increase the FiO2 or increase the PEEP or EPAP, but you really need to have a good hard think about intubation in this setting. Let's review this tutorial. This was a tutorial about assessing the patient who is on the ventilator in the ICU, who might be on a ICU ventilator or a non-invasive ventilator, and we looked at controlled versus assisted versus spontaneous ventilation. I talked about how to build a breath from atmospheric pressure all the way up to positive pressure. I focused heavily on pressure-limited modes of ventilation, as these are by far the most common modes in the ICU. I specifically looked at pressure support ventilation and explained that pressure support is essentially the mode that we use in non-invasive ventilators. We also discussed pressure control, volume guaranteed pressure control, and volume control ventilation, and then I briefly discussed non-invasive ventilation at the end. The next tutorial will be the first that looks at the basics of chest imaging in the ICU. I'm going to discuss radiologic lung anatomy and then talk about the placement of lines and tubes on the chest X-ray. I'll see you then, and I guarantee you'll learn something. So that was the basics of assessing a patient on mechanical ventilation. Again, there is lots more material on this topic on my blog and on my YouTube channel. And if you're enjoying these tutorials, please subscribe and leave me some likes and a couple of comments below.